This is Dr. Robert Elder. I'm a pediatric and adult congenital specialist in cardiology at the Yale University School of Medicine. Endocarditis, also known as infective endocarditis, is a clinical diagnosis and major problem both for adults and pediatric patients. There are about 10 to 15,000 new cases a year in the United States. Major risk factors include IV drug use, prosthetic valves, abnormal cardiac anatomy including congenital heart disease, poor dental hygiene, diabetes mellitus, chronic hemodialysis, HIV, intravascular device, or concurrent infections such as wound infections. Rheumatic heart disease, which used to be a major risk factor, has fallen dramatically over the last few decades. The diagnosis of infective endocarditis is based on the modified Duke criteria. Definite infective endocarditis requires either 2 major criteria, 1 major and 3 minor, or 5 minor. Major criteria are as follows. Number 1, echo findings consistent with infective endocarditis include either a vegetation, perivalvular abscess, or valvular dehiscence. Number 2, microbiology, a typical organism isolated from 2 separate blood cultures, or an organism consistent with endocarditis isolated from persistent cultures. And number 3, a new valvular regurgitation. An increase or change in the pre-existing murmur is not sufficient for this criteria. There are 5 minor criteria. Number 1, predisposition, such as a heart condition or IV drug use. Number 2, fever. Number 3, vascular phenomena, including major arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, or Janeway lesions. Number 4, immunologic phenomenon, including glomerulonephritis, Osler's nodes, Ross spots, or rheumatoid factor. And number 5, microbiologic evidence of infection that is not consistent with one of the major criteria. So for example, a positive culture on one occasion, and then the patient gets treated with antibiotics and there are no subsequent cultures. The clinical presentation may be either fulminant or insidious depending on the organism and the extent of cardiac involvement. Transthoracic echocardiography may be useful but has limited sensitivity, especially in adults, and transesophageal echo is often needed when infective endocarditis is of concern. Across the age range and spectrum, streptococcal species and Staph aureus are major pathogens. Among IV drug users, Staph aureus accounts for more than 50% of cases. Enterococcus endocarditis is commonly associated with hospitalization and bacteremia. Blood culture data is critical to target treatment of the underlying pathogen and should be done in conjunction with expertise from infectious disease. Mortality from infective endocarditis ranges between 10 to 20% depending on the patient, organism, and clinical context.